Thank you very much for inviting me to talk, and it's the third year I think I've talked at this, and it's actually a great pleasure and it's a real honour, and so thanks to Imogen for organising this again. And then thinking about brain metastases, this I think is one of the one of the more challenging areas to talk about, and I don't know where the slide advance is. Where's the slide advance?
It's that.
That, okay, right. And does it work? There. So all I wanted to say here is that with this first slide is that I started to think about it from a patient's point of view, but of course I'm not somebody who's got melanoma, and I'm not somebody who's had brain metastases, and it just made me think about oncologists and what we know. So people have lives, and they have lots of aspects to their lives, and they discover the zigzagging pathway that represents a human being's life with lots of different things happening. And then the interaction with somebody like myself is just a very small part of it. So of course I don't really know all of the stuff that happens in people's lives and how that affects them. And so one just has to look at the next slide from my point of view, it's a degree of humility. But nonetheless, one has to recognise that when we deal with when we talk about brain metastases, that these have a very big impact on the whole person. And as an oncologist, we only see a snapshot of that. So that's the point I wanted to make. Let's just start with a couple of technical things. So we're talking about brain metastases, and the points that I wanted to show here was that I'm sure we know what the shape of a brain is, and I guess that we're familiar with the fact that different bits of the brain have different functions. And so when something affects the brain, it will affect functions. And many of these are these are more than just somebody having loss of the use of an arm or a leg or something. It feels very personal. It feels very strange to not have for the brain not to work perhaps in the way that we expect. And you can see that here there are areas described, so perceptions, spatial relationships, depending on which side of the brain, affecting speech, emotion, sensations, behaviour and memory, and thought and reasoning. So something affecting your brain is, I say, a very personal thing. It's more than just functional effect. Just down here at the bottom, we have the cerebellum that coordinates movements. And one of the technical terms you hear sometimes is they talk about infratentorium or supratentorium. Well, that's the tentorium is this kind of layer here, and it just means this bit, which is very unique to us as humans, this big bit of the brain about thinking, and this bit, which is very much about coordinating the way our movements. And so that's when people describe metastases. And the other thing over here is just this section through a brain on the CT scan, and the folds here with the white and grey matter, which is where the actual action takes place, and these ventricles in the middle, which sometimes, one of the issues about this is you can see it's a very symmetrical structure, but sometimes that symmetry gets lost because of the effect of brain metastases. So how does that affect people is the first thing to think about. And so as a doctor, we think about people in terms of symptoms. We think very physically about these things. And that's the kind of thing I'm talking about here. I'm not going to go into great depths, but brain metastases can cause headaches and they can cause fits. And those are probably the two biggest things we think about. They can cause loss of function. So, for example, somebody might find suddenly that they can't use their right leg when previously they could, and it feels like a stroke, and initially they may end up in A&E, and a stroke might be what was diagnosed, but in fact a scan reveals a different pathology. So those are the commonest features. Those headaches occur because you get the lump in the brain and you get swelling around, and it's the swelling and the pressure of that swelling causes symptoms. It also causes nausea. People can be sick as a result of this. But also, if you think back to that symmetrical structure, sometimes you can get the symmetry is lost and it can push into those ventricles in the middle. Push into these ventricles, can push the midline across, and again that can make people feel very unwell. So these are the kind of the physical aspects of it, and the thing that people would fear is finding themselves not able to think as clearly as they could. And certainly if there's a lot of pressure, people's thoughts are clouded, people can become confused. But also if specific bits of the brain affected, they may find speech or understanding of speech affected. So these are frightening things. And then the other two key aspects of that from a medical point of view is one is the use of steroids. And so using steroids, commonly one called dexamethasone, relieves that pressure very quickly. And that has a very, very big effect. So somebody can have functional loss and get better within a day because they've started steroids. And the other thing is the use of anticonvulsants. And certainly if somebody has a fit, then they are definitely indicated. And there's some controversy about whether people should go on them prophylactically if they've got spread to the brain to try and prevent a fit. But this is only one small part of it. And this is a framework that doctors think about, not patients, not necessarily the public, but doctors think about in a palliative context about how to structure people's experience of an event like having a brain metastasis. And I started thinking about this particular aspect only last night, and I was trying to work through my understanding of what patients have told me of the kinds of things that they experience into these categories. And I'm not telling you that's how this is, but really I'm saying that you could write your own bit on this. I very much hope none of you have brain metastases, but some may. But even without it, there's that fear of it, that concern, could this happen to me? And that colours one's perception of that journey through with this particular cancer. So again, I'm not going to go through all of these in detail. You can read them for yourselves, but these are the kinds of things one might be concerned about. One I'm going to highlight particularly here, we're talking about social things that people may be concerned about, but there's this one here, driving. And so driving is something that really, it's bizarrely, when I give bad news about brain metastases, it's not the brain metastases and the implications for somebody's life that has the biggest impact. It's when I say somebody can't drive. That is an enormous effect on people's lives. And so I thought we ought to just briefly have a few slides on that. I've put up here two references, one directly to the government and the other one to the Cancer Research UK excellent website. And then this is from the CRUK website, and you can read that. But essentially it's saying if you've had a fit, or if you're newly put on anticonvulsants, or if somebody's got a rapidly growing brain cancer, they can't drive. And I guess we can imagine why that would be. And this is from their website, but they remind us that there are quite significant penalties for not doing this. And the point about this slide is to say actually there is hope, because although this is written down and saying you must not drive and you must notify the DVLA, all of which is true, the next two sentences say relicensing may be considered if. And this really does happen, and increasingly is happening in our practices. So people are getting licenses back, so that if somebody has a solitary lesion that's been treated and a year goes by and they're stable, then they're in a position of reapplying. And I have a steady flow of DVLA applications or questionnaires from the DVLA that I have to fill in with people seeking to get their license back. So there is hope in this as well. It's not just saying nobody can ever drive again. And the fact that that's happening does imply that there is hope for people with brain metastases, because you don't get to this point of getting your license back if actually nothing works. And the point is that stuff does work. So let's think about the treatments. So I'm a medical oncologist, so what I focus on is in terms of drug treatments, but I'm also going to talk about stereotactic radiosurgery to some extent and within the limits of my own understanding. So the drugs I've listed there are the ones that we're familiar with. In fact, I've just listened to Simon talking about them, and I gather that Willem has been discussing them earlier on. So I guess you're familiar with these. This is my overall kind of chart, which I update periodically, which is what are the benefits of these drugs. But this is looking at people as a whole with melanoma, not just at people with brain metastases. And here we have the familiar drugs. So at the top is the one that is dabrafenib and trametinib, the molecularly targeted drugs that Simon was just mentioning. And here we have the trials. Just focusing on that, we can see that there's a response rate overall of 68%. That's so 2/3 of people get shrinkage of the disease generally, and that we can see a survival at 1 year of 74%, and you can see the rest of the figures there. So that's one of our standard tools. Here we have the combination of immune therapy, again, the mainstay of what we do. And again, we can see that the median progression-free survival very similar, about a year. But at 3 years, more people than with Dab-Tram are still without progressive disease. And again, a slightly lower response rate, but nonetheless a significant response rate with combination immune therapy. And then we also have monotherapy again, and we get these figures in terms of their responses. So they're sitting at the top of the chart here because they are the most active drugs, and this is the mainstay, the main tools we use for which we offer to people with metastatic melanoma. So here's the rub. So this is the graph from trametinib, from that trial, with the blue line showing what we now would call standard treatments in terms of overall survival and progression-free survival. But then when we look at how that trial was constructed, we see this, that the eligibility for the trial excludes people with active brain metastases. It doesn't tell us about that population. And now we're going to just see exactly the same thing here. So again, this is a graph which I'm sure my colleagues have already put up in multiple occasions, showing the progression-free survival and overall survival for people with a combination and monotherapy, but immune therapy here. But again, that trial is constructed. Sorry, pressing the wrong button. To exclude people with active brain mets. And you can ask a question, well, why would that happen? And I think the answer is that drug companies, their top priority is to get their agents to market, and you can say that's a shallow capitalist purpose, or you can say that getting it to market helps the most people as rapidly as possible. Well, you can look at it either way, but the point is that they therefore want a narrowly defined population who are most likely to benefit to get a license, and then to try and tidy up issues about people outside those categories later on. And it was certainly an issue that, based on those data, when we first could use dabrafenib and trametinib, NHS England would not allow us to use it for people who had brain metastases. And even now, there are restrictions on people getting access to combination immune therapy if they had symptomatic brain metastases. So there are these trials excluding people with brain metastases have consequences in the way that funding bodies operate. There was a lot of pressure, I should say, from Melanoma Focus. I think Poulam led quite a lot of that, which is how NHS England retreated from that and have made these agents more accessible for people who've got spread to the brain. And in fact, that was very important, because I think that pressure was about 2 years ago, and that preceded the data that I'm now about to show you, and was based very much more on our anecdotal experience that these drugs work for people with brain metastases. But now we have evidence supporting this. There are a number of trials, but I'm going to focus just on 2 of them. So the first trial I want to talk about is one of the combination immune therapy, this backbone of what we offer people with spread to the brain. And so you can see that the patient population here, they have to have had proven melanoma. They did have brain metastases. Performance status 0 to 1, sorry, it's technical jargon, but you may be familiar with it, but essentially means that it means all of you. It means you're up and about, you're working, you're attending Melanoma Patient Conference, but you're not resting in bed half the day, for example. So that's what that means. You're picking the fittest patients. They had to have measurable brain disease, and importantly for this trial, they were without symptoms, and they had some of them had previous treatments. And you can see the patient population down there, which I'm not going to describe. And they had very much conventional dose immune therapy. And so what we see here, if we split up the outcome, is between the brain and the body. Here are some definitions for the technical definitions. By a response, we mean that a tumour has at least shrunk by 30% in terms of a linear measurement. And a complete response means you cannot see it on a scan. Doesn't mean it's gone away, but you can't see it. And progression-free survival means that you're measuring the time from start of treatment so that either, unfortunately, to a point where somebody dies of whatever cause, or the point where the disease starts growing and grows beyond a certain threshold to say that you're convinced it is definitely growing. So if we look at this, the response in the brain is actually pretty good. And I think that's the single most important piece of information, that we do see shrinkage of brain metastases in the brain as we do outside the brain. Now, this is, I think, 76 patients in this study. It's a relatively small sample, so this may be the play of chance. But it is interesting that we see more people having disappearance of metastases with immune therapy than in the body. the partial response, we see about a third of people, unfortunately, with disease that progresses through the treatment. And I highlighted these in red because I'm going to come back to these figures in a future slide. So I want you to remember those figures. But we're looking at 6 months progression-free survival, so people alive and without disease growing, basically something like 2/3 of patients, and even something close to that, even at 9 months. And that's a bit higher in the body. So the point is these drugs are active. But you will see how short that follow-up is. I don't know what the situation is in 3 years or in 5 years' time. We're still looking at figures around about a year or less because these trials are very recent. This is the curve. Now, I'm just going to pause. I've shown some of these curves before, but I just need to take a step back. I guess colleagues have also shown curves like this, and I hope they've explained the same thing. But I always have to remember that this is a statistical tool, but what this is real people. So statistics just describes what's going on, but these are people on this graph. And unfortunately, each time this graph drops, something has happened to an individual. And on this one, unfortunately, each time it drops, it's somebody has died. So we have to remember that. But nonetheless, what we see here is as this is going out over months, but more than a year, and all these dots here suggest that a lot of the data is incomplete. Nonetheless, there seems to be good survival over that short time period for people treated with immune therapy for brain metastases. And then here, these are the responses, and again, that's in the brain, outside the brain and in the brain, and then overall, and that's showing the time either to death or to progression. And again, it's still a lot of people are not progressing, and the curves seem to be flattening out. So it seems to hold promise for those people's future, but the data is still immature. These are the people who have had a response. So this is now not the total population in the trial, but a subset of that population, but those where the tumours have shrunk in the brain. And this is what's called a swimmer plot, because it's a bit like having lanes. Oh, I know what it is. This is like the triathlon or something like that. Anyway, but it's a bit like that. It's called a swimmer plot. But these are individuals, and what you can see here is these round things are where the tumours first are noted to have shrunk beyond that threshold. And actually, a lot of them are shrinking really early. So you're getting a rapid response, in my view, and then these responses are sustained. But of course, for a lot of these, we don't have follow-up data. And for some of these, where they've come off treatment, they're coloured orange, they still seem to be free of disease. So that these responses can be durable. It's not saying this is a solution to everything, but it is saying there is hope and there's in this. This now switches over to dabrafenib and trametinib. I'm being given a 2-minute warning, but we're not that far off the end. Maybe we are. Okay, I'm going to have to be quicker. I'm going to highlight this group A. You can see the groups here, but group A are asymptomatic. They haven't ever had any previous treatment for melanoma. They're BRAF mutated, and they're fit and active. Performance status 0 to 1. And again, with dabrafenib, trametinib, 76 patients, the response in the brain, 58%, so a very good chance of shrinking the tumours. Not many people getting complete response. And at 6 months, 44% have no progression, 12 months, 19%. So the point here, if you think back to with the immune therapy, this is working very well in the short term, but is not delivering you long-term disease control. So I think one has to think about how we use these drugs in real life. And those are the curves. And you remember the curves that I just showed you for the immune therapy were higher and flatter. And that's really the point. So these are good short-term treatments in my view, but I'm not sure that for most people they're going to deliver long-term control. I'm not going to go through that. That was just really to say other trials are available. Okay. It's really important to flag up this. I'm going to crave another few minutes because I want to just try and get through this. We should just be aware that radiotherapy plays an important role. This is pre-2013 when people went into a frame and they had to have their heads held still because otherwise if they moved, the radiotherapy would miss the area they were trying to irradiate. But the concept of having highly focused radiotherapy destroying those lumps in the brain was nonetheless quite an old one. But now This is with computer-aided equipment. So this is a linear accelerator that moves with the patient, and so using real-time imaging can track these lesions so that can get really finely focused radiotherapy on the spots. Now, this is all work done by colleagues, and these slides are borrowed from my colleague Paul Sangera, who actually does this work. I just wanted to flag up that there are commissioning guidelines. We are not in a position of treating everybody because NHS England still limits the way this is used. But nonetheless, if people are fit and well, have a good prognosis otherwise, if there's treatment that's controlling disease outside the brain, and if there's no reason to immediately go to surgery because they're unwell because of brain swelling and they need a lump removed, then this is what we should be using. And this is very widely used. There are multiple centres around the country that do this. I think all I wanted to try and say here is these are old data, so this is not where we are currently, but I wanted to flag up that if we go back historically to people with brain metastases in Birmingham, in the red line were people where we had no useful treatment at all. And in the other lines are people who are getting treatment. And you can just see the lines are moving to the right, that there is a change. As we introduce the new treatments into the practice, more people are surviving, and they're surviving for longer. And in particular, there's this group that even in these old data, those people who had stereotactic radiosurgery, the radiotherapy with those mobile linear accelerators as I described, seem to have the best chance of being long-lived survivors. You were looking out here at 4 years, for example. So they have the best chance of being in that group. And this is very much seen in other groups as well. And so this is a trial of, this is not a trial, this is a retrospective look at stereotactic radiosurgery. And I think the key thing that I wanted to get across here is this, that people had stereotactic radiosurgery only in this retrospective study, that in terms of getting long-term disease control, so that is they got no new brain mets after their treatment after a year, only a minority had that long-term control. But when you add in immune therapy, then more people get long-term immune control. So there's a logic to saying, should we be using this radiotherapy, this targeted radiotherapy, along with systemic agents? And that's the wrong thing again. I want to just briefly mention this, and I'm going to finish with what I do in Birmingham. Just to be aware that there is always a concern about steroids. These are data looking at a whole lot of mixed literature, but in very briefly, if people are on immune therapy and we give them steroids late on, broadly speaking, although I want them on the lowest dose possible, I'm not worried it will stop their treatment working. But I am concerned if people are on steroids when they start immune therapy, I am concerned that it might reduce its effectiveness. And there's various bits of data supporting that point of view. And that then colours what we do. How do we treat people with brain metastases? Well, we are honest about it, as I think I've tried to be with you today. It is bad news to have spread to the brain. We try to give people bad news carefully about that. But we do need to give people good information so they can make balanced choices. These are the things that I look out for, but I'm not going to be given time to go through them all. But there are a set of things I will look out for. But it'll become clear on the next slides, which is where I'm going to be finishing. So this is how I would look at people with brain metastases. So if we take the middle section, and we're taking people who have had scans, and it looks like radiotherapy or surgery, targeted treatment in both cases, could be very useful to these individuals. It's technically possible. And the best group of all are the people where the disease is not very high volume, either in the brain or outside the brain. Well, actually, in many of those people, I would like to delay starting their drug treatment. I want to give them the targeted radiotherapy. They normally get steroids to cover them for that period, get them off steroids, then give them their immune therapy. That's what I'd like to do. But if they've got lots of disease outside the brain, then I would probably want to get started with their drug treatment rapidly to control the disease everywhere. And then once they're on treatment, then I would look to be giving them stereotactic radiosurgery. But both of these groups have got no symptoms from their disease in the brain, and they're off steroids. This here, we got a different group where they have symptoms and they're on steroids. And here, I would like to get their treatment their brain disease under control and get them off steroids. So refer them for surgery, etc. And then give the immune therapy. And these are the difficult people, difficult cases, I should say, people in a difficult position with either asymptomatic, but they can't be treated. But maybe if we start treatment and we can give them brain-directed treatment later, or here, the most difficult population of all, or people in the most difficult situation, they're on steroids. What else can we do but just get started with immune therapy? And some of those, we may still be able to come back and treat them later. And in all of these, what then? Could we, if they've got a BRAF mutation, could we change their position? So somebody in this group who have the worst outlook, if we can give them BRAF therapy, rapidly shrink the disease, make them feel better, get them off steroids, can we move them into this group? And that same question could be asked for all of those other groups too. And that, I think, is bringing me to the end. So I just want to give acknowledgements. This is the brain-directed therapy team in Birmingham, and Paul here lent me those slides and has talked me through a lot of this. And I learn from these people all the time. And that's our MDT, except that Claire has now left. Oops, I've lost something. Somebody's blanked it out. But anyway, our CNS team has slightly changed. But that's our MDT, and so I just thought I should give acknowledgements to them as well.